It's a real honor to be here at this session at the OIS. I think this is, I believe, the first time we've had glaucoma in a spotlight session, so I'm well esteemed to be here amongst all my colleagues, and also a lot of new faces here in the industry and the financial world. So I am going to speak on my perspectives on the unmet needs and the opportunity and what's out there and what's coming in MIGS, or Micro Invasive Glaucoma Surgery. Now, by way of disclosure, these are my disclosures for relevance and also in general. And what I've highlighted in yellow here are the variety of different industry partners that are invested in this space. And as many of you know, I think there's up to $750 million invested in glaucoma surgery, I think indicating the interest in this area. Now, by way of just introduction about myself, I am a glaucoma specialist from the University of Toronto in Toronto, Canada. I have some advantages being in that OUS country, but not too far. And so I've had the good fortune of being able to work with many of these MIGS devices and MIGS companies, and perhaps that's one of the reasons why I'm here. Now, when I was asked to give this talk, I realized that there are so many of you from different varieties of backgrounds and expertise. And obviously, perspective makes a big difference. How many of you know what this picture is here? Nothing to do with glaucoma. It's a solar eclipse. All right, Paul, you can graduate. That's impressive. This is a solar eclipse, and I put this up here just to kind of show that, you know, I think it's often important to look at the question at hand or the need of the day from different perspectives. Sometimes we have to take ourselves away from the spotlight, look at things from a different angle. I think we've heard this already from Bill. I'm coming from a clinician perspective. In the end of the day, I'm taking care of patients, and at the end of the day, we're treating a disease for which we, of course, have many unmet needs. Now, for those of you that are not glaucoma specialists, I do see a couple of you out in the crowd, so Rick and Tom and others, and Randy, you can close your ears. I think I saw a few of you guys in here. Glaucoma is defined as an optic neuropathy with classic visual field loss. Elevated pressure is a major risk factor, felt to be due to an increased resistance in the trabecular meshwork, SEMS canal apparatus, leading to elevated pressure. There are other risk factors as well, and the only proven treatment for prevention of visual loss is IOP lowering. Now, keep in mind, the more advanced the disease, the lower the pressure needs to be. Normal pressures can range from 11 to 21, and typically we're targeting down for advanced disease into those low digits. Now, I just mentioned this. I think it's important to put that in perspective. We're not going to be speaking for a lot of the advanced patients. Now, how do we currently treat our glaucoma patients? This is not necessarily my treatment paradigm. I have the benefit of having access to new technology, but I think that traditionally around the world, it's medications, it's multiple medications, it's lasers, it's multiple medications again, and then there's a long gap or a chiasm before we and our patients embark on the journey to surgery, typically trabeculectomy and tube shunts, and there are reasons for that. Keep in mind, this has not changed over the last 40 years. It's a long time, almost as old as I am. As far as glaucoma drops are concerned, this is our mainstay of treatment. We know, of course, that over a couple of years of treatment, most patients require more than one medical drop, and most patients are not compliant. We won't go into a litany of all the issues with drops, but drops certainly have been successful. They can work, but we have concerns and issues with compliance, side effects, and cost issues as well. What about lasers? Non-invasive is fairly safe, but the efficacy is limited. The success rate is somewhat limited. There's an attrition over time, and the response rate is low, and there's questions of repeatability. And what about surgery? Well, I have a lot to say about surgery. I don't have a lot to say about trabeculectomy, but I thought I'd put up this video here just to show a standard trabeculectomy, although this is not necessarily a standard intraoperative complication, but one that we dread, the intraoperative choroidal hemorrhage leading to almost an expulsive situation. And this is, of course, our tried and tested gold standard in glaucoma surgery still to this day. Trabeculectomy still have significant baggage, even from recent trials by high-quality sites. There's a variety of complications that can occur intraoperatively and postoperatively, making it less desirable for us as clinicians and our patients to embark on this road at any stage of disease, even when patients are going blind from the disease. Now, when I look at our practices and I look at our patient profiles, proportion of patients in an average practice, not necessarily mine being a more tertiary level, but in an average glaucoma practice, about 10% of patients are those advanced, progressive patients that need to have more major surgery. 30% are cruising. They're doing well. They're controlled. Things are fine. They're on 1 or 2 bottles, and they're stable for most of their lifetime. But the middle class, and of course I'm in the US here, so we all know about how important the middle class is, sometimes often neglected, but yet holds all the power. Middle class is that mild to moderate glaucoma, 2 or more medications, for example, and they're the ones that are in between. I look at them in between. They're at risk still, but they're not necessarily so bad. They're not necessarily so advanced. But we don't have options for these middle ground patients, middle of the road patients, and that's where clearly the need exists. Now, when we look at how we treat glaucoma in terms of globally, we see the majority of patients are in this $5.5 billion industry of pharma medications in glaucoma. Lasers occupy about 12%, and filtering surgery and other surgeries are a very small portion currently of glaucoma surgery. So certainly it's a very small portion. And if we're looking at MIGS to enhance or to simply supplement this area, we certainly are looking at a small target. However, we know that the need is greater than that. In the US, we see again a similar like profile. About 10,000 tubes done annually, 50,000 trabs, and about 120,000+ laser trabeculoplasties. That's basically the raw numbers. Medications, of course, the predominant level. Now, one of the interesting things that have come out of MIGS, and we'll talk a little bit about this, is the coincident disease of cataract and glaucoma. We know some of the facts of glaucoma, of course. We know worldwide this will affect over 60 million in the US, between 3 to 6 million people have glaucoma. Many, unfortunately, are undiagnosed, and this is a common cause of blindness around the world. Now, we also know in the US there's about 3.3 million cataract procedures, many of them of which have glaucoma with the disease. Most of them which we do not proceed with traditional surgery because of the risk profile, and also that phaco can also be somewhat helpful. But that chunk is important to remember when we look at the potential market here in terms of a new alternative intervention. We look at about 20% of this population, it's about 600,000 patients with comorbid disease that would be a candidate for a less invasive procedure. If we add all these numbers up, cataract and glaucoma, if we add the numbers of lasers being done here, we potentially see that this is a fairly large market, approaching $1 billion, simply looking at the numbers today. So the market and the need is clear. The question is, do we have the technology? And this is where Bill has talked about innovation. For those of you who can't read this, the bottom says, I'd be happy to give you innovative thinking. What are the guidelines? And of course, that's not innovation. Now, we know, of course, when we talk about glaucoma, we're a little bit of a different breed. You probably already know that already. Refractive, phaco, that was one glaucoma guy laughing, right? IOL, retina, ophthalmology is diverse. Glaucoma, we're a little different. We're a little skeptical, and there's a good reason why. We have a progressive chronic disease. We need long-term results. We need to see, we need to see the money on the table at the end of the day. So these are all the factors. Again, I think you're already well aware. This group is very aware of some of these factors. We balance risk, efficacy, and effort. We determine need, look at design, funding, basic science, all the rest of it. I think I will take a step back a little bit and talk about evidence. Sometimes it is hard, to be honest with you, as a clinician, to differentiate the difference between some of the marketing and some of the evidence. And certainly being somebody who is a strong believer of evidence-based medicine, this is an important aspect, specifically with glaucoma. Truly, we're talking about disruptive medical innovation in this area here, and the creation of a new space. Now, this is obviously targeting a group of patients and surgeons whose current approaches are not best served by current treatment methods, and this is where MIGS really comes to play. Now, what is MIGS, by the way? This is a rhetorical question, but we've seen different terms being used. Minimally invasive glaucoma surgery, micro invasive glaucoma surgery, modern inclusive glaucoma surgery, mom's ideal glaucoma surgery. Well, I guess it could be any of these, but it's not the MIGS fighter, by the way, that old Russian fighter jet. Now, MIGS, which is a term I coined back a number of years ago, and recently have published an article kind of talking about perspectives of MIGS, is how we currently define MIGS. This is important to take note as we talk about the numbers and the technologies here. So this is an ab-internal approach, typically clear corneal, sub 2 millimeter. We're familiar with that with phaco, of course. There are no typical conjunctival incisions that are made, which is traditional in glaucoma surgery. It's minimally traumatic. There's negligible disruption of normal anatomy and physiology, and devices that we use have to exhibit excellent biocompatibility. It must have at least modest efficacy, and you see I underline, or I've emphasized modest. We're not talking about a dramatic procedure. We have those already. It has to have an extremely high safety profile, a rapid recovery, and ease of use are all important with this procedure. Now, it's important to mention again, this is not a procedure to lower pressure down to 12. Outcomes of this work are typically based on reduction in medications. That's often our outcome measures, not necessarily how low can you go. Its intervention is earlier, and often we combine with phaco. We're in the eye already. These patients have glaucoma, they're on drops. Let's treat the disease and get them off their medications. So the typical patient profile is different. When we look at the market out there, who has glaucoma surgery, on the column to your right, it's very different than the column to your left, potentially here. Mild to moderate disease, pressure targets in the mid-teens, that's typically our target. The key with MIGS here, the whole idea, the concept here is to get to these patients before they become advanced enough, where they really need a more aggressive procedure. That's the point of MIGS. Now, some of you in this room may have glaucoma, I don't know, but certainly you may have relatives or friends that do. What is your choice? A trabeculectomy that we know for sure can lower pressure down to 12. It's got a fairly intense postoperative course. It has some known risks, potentially devastating. Or a new procedure that's minimally invasive or micro-invasive, as we talked about, pressure of 13 perhaps, but you got to take a bottle of drops, and the risk is very low. Or what about your choice of medications? You can get a pressure of 15, you're on medications, 2 or 3 bottles, there are compliance to side effects, or we have a procedure that can get down to that level without medications potentially. Early, very easy postoperative course, low risk, and the future options of future treatment are available to us if we need. The other question to ask is, who will be doing surgery in the future? Will it be in the hands of a few like we currently do right now in glaucoma surgery, or will it be amongst the generalists? Remember the glaucoma surgeon mentality. For us, it's all about lowering pressure. That's how we're judged on. It's more important than even the risks when we look at treating our patients. This is the expectation of our patients in our referring base. And generally speaking, we, and I use the collective, we are conservative, traditional, based on current treatment paradigms, need the long-term evidence before crossing that chiasm. And there are some differences worldwide. While the general ophthalmologist, perhaps is in that more open-minded group, perhaps in terms of considering newer procedures. They're not interested in the effort of all the postoperative course. They don't have enough surgical volume necessarily to try a very different procedure. And they'd like to offer a safe alternative to what we currently have and combine with cataract surgery. Now, in Canada, at least, I can tell you, these are all the options we have for open angle and angle closure glaucoma. There's a lot of options out there you see here. I'm sorry for my U.S. counterparts here that don't have access to a lot of these different devices yet, but we do have a fair amount of options available to us. How do we determine what procedure to use to put yourself in the mind of a clinician? Well, we want to determine whether it's open or closed angle, obviously. One of our big questions is, what is the pressure target here? How much medications can we use? How bad is the glaucoma? What is the medicated IOP? And the surgical risk profile are all factors that we need to take into account. Now, the other factors here that we need to consider also that are important to remember are surgical effort, postoperative recovery, our technical skills, we don't have to talk about that too much necessarily, and reimbursement. Now, this is kind of how I look at my patient population. There are 4 buckets. Some of these terms are new. We'll see whether some of these take off. Maybe they won't, but MIGS certainly has. So you can see here that I've divided these surgical options based on pressure target. Whether it's MIGS or bags, as we'll call another procedure, or TRAB, these are all options that we have with our patients here. Now, what is blebless ab-external glaucoma surgery? This is typically an external approach to lowering pressure without a bleb. These patients are typically candidates for moderate to advanced glaucoma. The risk is higher than MIGS, and the pressure target is typically in the low to mid-teens. And there are 2 examples currently on the marketplace, at least worldwide and currently being studied. The gold shunt is placed externally from Solex through a scleral dissection, and aqueous essentially is diverted into the suprachoroidal space, again, to an external approach, a blebless approach. So we're avoiding a bleb like we do in trabeculectomy. The other other item in this category is canaloplasty, which is an external approach to Schlemm's canal. This is a microcatheter that's used to enhance traditional outflow, again with the blebless procedure, but still externally. Now, these are more technical, typically. As you see, the dissection is fairly involved. Now, trabeculectomy, of course, we've already talked a little bit about. These are really reserved for the more advanced cases where they need low pressures, progressive patients at normal pressures. Now, there's some innovation in this space. InFocus is a company that is currently undergoing trial with the MIDI Aero, an ab-external approach to subconjunctival filtration, with a novel material, and we'll see where that goes. Certainly some interest in this area with a cleaner approach and perhaps less fibrosis. Again, we're talking about target here. We're talking about based on pressure targets, and we're talking about MIGS here in this case here. We can also look at severity. Again, MIGS typically reserved for the more mild to moderate disease as opposed to the more advanced disease. Now, this is the space we're looking at again. As interventional surgeons, MIGS can fit into any of these spaces, whether it's after one drop, after lasers, or before trabeculectomy. Now, there are a variety of different outflow targets in terms of current device development. There are SEMS canal or conventional outflow approaches. There are suprachoroidal approaches, which is considered to be the non-conventional outflow, both physiologic again. And then there are the scleral or subconjunctival approaches. Remember, the targets typically with these MIGS procedures are looking into the angle. This is the canal of Schlem, as you see here. This is the target space we're looking at for SEMS canal procedures. And this is the suprachoroidal space, which is a target for suprachoroidal procedures, which is the base of the iris insertion. Currently in the US, these are the commercialized and investigational, and we'll be focusing on some of the devices here with our next panel, looking at SEMS canal and suprachoroidal approaches, as well as subconjunctival approaches. Now, no doubt there are challenges in the MIGS space, like any glaucoma procedure, including healing and other physiological places of resistance. And this slide sort of summarizes where I look at these procedures in terms of MIGS. Subconjunctival are perhaps the most potent. SLEMS canal moderate and suprachoroidal moderate in terms of potency. The risk profile is a little larger or greater with subconjunctival and less so with SLEMS canal, and low with suprachoroidal as well. Ease of use, which is a factor. Perhaps SLEMS canal is somewhat more difficult, requires a gonial view. I still think it's certainly quite manageable. But subconjunctival and suprachoroidal approaches seem to be a little easier to adopt. Each space has their own issue, whether it's bleb issues or episcleral healing or hypotony potentially with subconjunctival procedures, whether it's uncertainty of placement or having a floor below which we can't lower pressure any further, or further outflow resistance, whether with SEMS canal, or a suprachoroidal, which are issues with regards to the choroidal space potentially, and healing as they are with all. Now, as we look at some of these procedures here, and we'll briefly go through some of the options we have in the marketplace here, we know with the SEMS canal devices, we've had a number of different approaches that have been used. Remember, these approaches are typically addressing the proximal outflow to enhance aqueous outflow to the distal outflow vasculature of the eye. The Glaukos eye stent, of course, has been the most studied of these devices. We hope imminent approval in the US and around the world. We've had a number of years of usage. Titanium stent device placed through the inner wall into the canal. In this video here, we'll just show the procedure here as we perform this again using a clear corneal incision. This patient actually is a phakic patient. It's a solo procedure, someone who had poor control with pressure with mild to moderate disease. You can see the pigmentation in the angle visualizes this canal quite nicely. And notice the self-trepannating tip inserts itself at the inner wall, guiding the rest of the lumen into the canal with an open pipe, and the snorkel ends up in the anterior chamber. Often we see a little bit of blood reflux as expected. And you can see this procedure here is done through a gonioscopic view. The idea here is now we've gotten through the resistance at the inner wall, which typically is found in glaucoma. There's been a lot of work done on single stent placement with significant reduction in medications and target pressures. Here we're showing an example of using two devices here in the same eye. And one of the things that we've really been looking at is the ability to titrate these devices. I think this is an exciting area of MIGS procedural work, being able to allow us to place multiple devices to titrate the pressure to a lower level. I'll let some of our speakers further talk about some of the results, but basically what we have found that the addition of 2 or 3 stents provides a lower pressure level as opposed to 1. However, 1, I want to make it very clear here, does lower pressure quite well and certainly can get to a pressure target, for example, at 18. So really this allows us to select our patient profile and allows us to then utilize devices accordingly. Now, an alternative approach is a scaffold placed within the canal of Schlem. And this device essentially is somewhat similar, yet provides a scaffold with windows allowing aqueous to flow into the canal. Very similar approach as we've seen with the previous procedure and the approach that we've described. And here's a picture of the device here, post-operatively showing the device in the canal again, allowing us to enhance aqueous outflow. Now, we talked about the suprachoroidal space. We know that this is a potent pressure gradient into the suprachoroidal space, allowing aqueous to flow out of the anterior chamber. And a variety of devices have been designed. The Glaucos iStent Supra and the CyPass Shunt are both devices that have been currently in study that permit aqueous to flow into the suprachoroidal space directly, as you see here, allowing a fairly potent pressure reduction that may occur. Our last space is subconjunctival. The Aquasys procedure is an ab-internal procedure. You can barely see the device, barely see any conjunctival elevation here, shunting aqueous from the anterior chamber to the subconjunctival space, allowing pressure to be reduced in an effective manner. So those are some of the MIGS procedures. When we look at our options we have in front of us here, again, typically I like to base them on pressure targets. The lower we need to go, the more aggressive the procedures need to be. Remembering that when we look at the treatment landscape, this is what we're looking at right now between risk level and IOP lowering. Medications and lasers, low risk, but not very effective at lowering pressure. Trabeculectomy, high risk, but certainly can lower pressure very effectively. That middle group, again, is the group that is lacking currently with options. This is where we have a variety of smattering of devices, the MIGS space, ultra low risk, reasonable IOP lowering that can be effective. And I'll put this slide up just to finish off, showing our treatment reality today, as we described earlier. And hopefully as we go forward here, we'll see the ability to add MIGS as an option early on in the disease, whether solo or combined with phaco emulsification. Thank you very much. I look forward to our discussion with our panel and further dialogue on this topic. Thank you very much.